question, use the Q&A tab at the bottom of your screen. Feel free to ask a question at any point during the presentation. Your questions will be addressed after the conclusion of the presentations. We will do our best to ensure all questions are answered. However, this may not be possible depending on the number of questions presented. A Q&A handout will be made available when the Enduring webinar is posted. When the webinar ends, you'll be automatically redirected to a new page to claim CME credit. If you are unable to complete the test at this time, you'll have 48 hours to do so from the time of this broadcast. And finally, if you experience any technical problems during the course of this webinar, please submit a message using the Q&A feature, and we'll have a technical expert there to help with your problem. I'd like to now introduce tonight's co-moderator, Dr. Alan Klein. Dr. Klein, past ASC president, is the director of the Center for the Diagnosis and Treatment of Pericardial Diseases and a staff cardiologist in the section of cardiovascular imaging, the Robert and Suzanne Tomic Department of Cardiovascular Medicine at the Sidell and Arnold Miller Family Heart, Vascular and Thoracic Institute. He is currently a professor of medicine at Lerner College of Medicine at Case Western University and is course director for valve diseases, structural interventions, and diastology imaging summit, currently his 23rd course. Without further ado, please welcome Dr. Klein.
Thank you, Kat. It's a great pleasure being here. I'd like to welcome everybody to today's presentation. This webinar was designed to provide education on the complexities of the use of echo in the diagnosis of cardiac amyloidosis, including the complementary role of echo and PYP scanning. Today we hear from the experts. We hear from Dr. Martha Grogan from Mayo Clinic and Dr. Rodney Falk from the Brigham, who share their expertise on amyloid, on the challenges of diagnosing amyloid, on patients with atypical findings, and the appropriate use of PYP scanning in the diagnosis. And you heard from the previous webinar, that was the basic. This is more the advanced course on amyloidosis. We will open the floor to questions following the presentations. Please submit your questions using the Q&A box. I would now like to introduce my co-moderator, Dr. Melinda Desai. Dr. Desai is very well known. He's the Director of Clinical Operations of the Cardiovascular Medicine at the Sidell and Arnold Family Heart Vascular Thoracic Institute at Cleveland Clinic. He currently holds Professor of Medicine and holds the Haslam Family Endowed Chair in Cardiovascular Medicine. He's also the Director of the Holcomb and Aortic Center at the Cleveland Clinic. Dr. Desai is very busy. Dr. Desai is an expert in multimodality imaging, and we're pleased to have him join us today. And now to begin the presentations. Our first speaker this afternoon is Dr. Martha Grogan. Now, Dr. Grogan is the chair of the ASC Task Force on Cardiac Amyloidosis and is the founder and director of the Mayo Clinic Cardiac Amyloid Clinic Center, the cardiovascular medical editor of the award-winning mayoclinic.com, and she also served as the former chief of internal medicine and medical director, assistant warden at the Federal Medical Center while fulfilling a National Health Service Corps commitment. Dr. Grogan conducts clinical research with a focus on cardiac amyloidosis and lectures widely. Please welcome Dr. Grogan.
Alan, thank you so much. It's really my pleasure to be here. Can everyone see my screen, I hope? Okay, we're going to have a whirlwind tour of echo challenges in amyloid. Is it amyloid or is it something else? Start out just taking a look at these and think to yourself, which of these patients do you think has cardiac amyloid? I'll let you kind of look at those. We're not going to have to vote, but we will come back to each of these patients later. And just from a high-level view, key points about amyloidosis is that patients very frequently present to cardiologists, and unfortunately, we are the most common subspecialist to miss the diagnosis. And really, we know now that it's not so rare, it's not universally fatal, and it's really becoming a chronic cardiovascular condition due to improvement in therapy, which is very, very exciting. Classic echo findings of amyloid are pretty easy, but I hope to convince you that we all need to recognize early disease and variants in the phenotypic images. So the echocardiogram is often the first suggestion of the diagnosis of amyloidosis. Here's a very classic two-dimensional image of cardiac amyloidosis. You're aware of the increased left and right ventricular wall thicknesses, valve and atrial septal thickening, restrictive filling patterns. reduced cardiac index and biatrial enlargement, as well as pericardial effusion. You should recognize that this is a cause of a false positive stress echo, especially with a hypotensive response, so think about amyloid. And strain imaging shows the classic bullseye apical sparing pattern. So that's the pretty easy type. And just a reminder that there are two main types of amyloidosis that affect the heart, AL and ATTR, and these are very, very different and have completely different treatments. Sometimes people say, I just want to learn about that TTR amyloid. Well, you can't learn about one. You have to know both in order to make the proper diagnosis. So especially wild-type transthyretin amyloid, we are recognizing that this is not a rare disorder at all. We've known for years that it's pretty common to find amyloid in autopsy series. But look at carpal tunnel, bilateral carpal tunnel release. 10% of patients, men over 50, women over 60 had amyloid. Heart failure with preserved ejection fraction, one series, as many as 13% of patients had wild-type TTR amyloid. Very important in the TAVR population, about 15% of patients have been found to have amyloid. And we are increasingly seeing that patients with spinal stenosis have amyloid deposits. That doesn't mean that all of these patients are going to go on to have cardiac amyloid, but we do see that commonly in our patients who develop cardiac manifestations. So here's a hot off the press study from Sweden where of patients who were a consecutive series over the age of 50, 37% of patients had TTR amyloid in the spinal ligaments. So really all cardiologists need to know about amyloid in general and including wild-type TTR amyloid. Well, here's a lady from Ecuador, 55-year-old, who presented with exertional dyspnea and fatigue, and you'll see her peristernal long axis images there. Here's her mitral inflow with a very short deceleration time, and the EE prime was markedly increased. Her EF was reduced. The NT-proBNP was over 7,000. So if you were going to take a poll, what would you think is the most likely diagnosis? And I know that if you're being honest, even though we're in an ASE amyloid webinar, most of you are not going to pick amyloidosis, and I would not usually either. But let's look at the history. She had bilateral carpal tunnel syndrome. She had a new anteroseptal infarct pattern on the electrocardiogram and new low voltage. She had mild proteinuria, and she had had a hypotensive response to exercise. So now the most likely diagnosis is much easier. So sometimes the echo is classic, and sometimes the history is classic, and we need to put those two together. This lady did not have early amyloid. She had very advanced heart failure and underwent heart transplant 6 months later. Her myocardial dysfunction is likely due to light chain toxicity and or vascular involvement. And this type of AL with normal wall thickness, with or without a reduced ejection fraction, occurs in about 5% of patients. So very important to remember that amyloid is not just a pure infiltrative cardiomyopathy. Here one sees the light chains demonstrating direct myocyte toxicity, and I really love the term that Dr. Falk coined, that amyloid is an infiltrative toxic myocardial disease. And once you recognize that, it will be much easier to recognize the variation in the imaging patterns and in the clinical presentation. So again, classic is pretty easy to diagnose, but there are all types of variation, and the variation of the pathologic extent and distribution of amyloid, as well as the circulating toxic components, really is what leads to these different phenotypes, including different clinical presentations. So it's not all about wall thickness. I just showed you with that AL amyloid patient, end-stage heart failure. Yet here's a patient with wild-type TTR with some of the thickest walls that you will encounter, and this patient is very well compensated, walking 3 miles per day. Here's an interesting 61-year-old gentleman who was sent for an echo because a murmur was heard on a pre-op evaluation for an inguinal hernia. So here you see the peristernal long axis view. And I'm just going to show you the apical image, Mayo format. So this is the left ventricle, mitral valve. Get that to play again. Now let's look at the apical images. Again, this is the right ventricle tricuspid valve. So you see this very marked tricuspid valve thickening, and there is definitely mitral valve thickening. Interestingly, there really wasn't very much regurgitation of any of the valves, and the aortic and pulmonary valve were both thickened. So if I gave you the quiz, you're also most likely not going to pick amyloid for this case. But indeed, when we look a little bit further, well, first of all, here is the strain imaging, which is suspicious that this could be amyloid. But now let's look back at the history. This gentleman who didn't seem to complain a lot had actually noticed himself that he had macroglossia. For about 3 years, it was getting worse. He had bilateral carpal tunnel syndrome or release 4 years ago. He had had an ENT evaluation for choking spells, and the ENT doctor noticed dental impressions in the tongue, and he had markedly elevated lambda-free light chains. You really want to make sure you get used to looking at these numbers. And he had amyloid in the fat in the bone marrow. He has AL, amyloidosis. And notice, too, that the carpal tunnel was 4 years ago. So historically, we have seen very, very end-stage AL patients, and I think we think that they get sick very quickly, but this is not always the case. He had had macroglossia for 3 years, so he has just started chemotherapy within the past month. Here's a gentleman who's 57 years old, and he has a history of hypertension and exertional dyspnea. He actually was referred to the echo lab due to a question of amyloid because he had had amyloid on a GI biopsy when he had an evaluation for GERD. But our echo report said no evidence of amyloid. Now I'm showing you some of the more abnormal pictures: left ventricle, right ventricle, mitral valve, tricuspid valve. It was noted on the transthoracic echo that he had thickening of the atrial septum, and here's the TEE showing a markedly thickened atrial septum. This is the right atrium, left atrium, and notice thickening of the left atrial appendage and the atrial wall. So I already told you that he had AL amyloid elsewhere, so that was part of the clue. And our great pathologist, Dr. Bill Edwards, pointed out to me that this patient had an unusual endocardial distribution of amyloid. He had only mild interstitial infiltration and almost all endocardial amyloid, which here you see the amyloid layering on the endocardial surface. And so that's why we had unusual echo, and I did not show you, but unusual MRI findings. And so pathology really explained this. This patient needed a stem cell transplant, and he stabilized with that therapy. Here's a lady who presented at age 69 with class 4 heart failure. She had a PYP that was mildly positive, I should say, and suggestive of TTR amyloid. Her screening for AL was negative, and she had no family history. So parasternal long axis images, you see that her walls are thick and the ejection fraction is reduced. Notice here on the short axis that she does have thickening of the right ventricular wall, and here's the long axis and the strain, which is abnormal. So I will tell you that this lady who had recent class 4 heart failure, positive PYP, classic looking echo, I was getting ready to order her TTR DNA sequence. However, then I looked a little more closely and I noticed that she was on hydroxychloroquine for 15 years. And indeed, her endomyocardial biopsy showed that she had hydroxychloroquine cardiac toxicity. She had no cardiac amyloid. We stopped her hydroxychloroquine and she improved dramatically. Her echo has shown regression and her heart failure has pretty much gone away. And then there have been other cases that we've reported and others of hydroxychloroquine as a cause of a false positive PYP scan. Here's a patient, a 76-year-old with coronary disease and prior myocardial infarction and coronary bypass who presented with heart failure. Now notice right off the bat that you see scar here. You do see some thickening of the posterior wall. Here's the short axis views. So this one, as we look here, notice this abnormal strain, but not in the usual pattern of amyloidosis. But what you see in this patient is that he has scarred areas due to his prior myocardial infarction, but the other parts of his heart have become thickened. And if we had serial echoes, we probably would have been able to see that. So this is a patient who actually has coronary disease, and wild-type TTR amyloid. And the clue for him is something that Dr. Tajik taught me to do, is always look at the right ventricle if you're suspicious of amyloid. And in his case, he had right ventricular thickening. So this patient had an unusual pattern of combined ischemic heart disease and cardiac amyloid. Dr. Tajik actually stole that and tweeted that out last night. Here's a patient that I recently saw. I sat down to read an echo, and they said, oh, this is very, very straightforward. Just need to know if there's a pericardial effusion. This is a follow-up study. So I'm looking at the echo, and I wonder if you can think of what was bothering me about this echo. How come I didn't just sign it off in a minute or two? Because it's obvious that there's not a big pericardial effusion here. Well, the malignancy was a thoracic malignant solitary fibrous tumor that involved the pleura, and the patient had had many, many pleural procedures going back about 6 years. And when I looked a little more, the history was pericarditis 2 months ago with a moderate pericardial effusion, and that's why we were doing this follow-up study. He had been treated medically. So now the sonographer is like, hey, this is easy. There's a trivial pericardial effusion. The mitral inflow actually showed abnormal relaxation, and there was no evidence of constrictive physiology. So they wondered what was bothering me. Well, this is what was bothering me. You see the posterior basal wall is thickened, it's definitely more thick than the septum, but that doesn't go along at all with his history. But because I'm always looking for amyloid, this always bothers me. And a clue to amyloid can be posterior wall thickening, especially up here at the base, not so much where we traditionally measure, and Dr. Tajik taught me that, and I pay a lot of attention to the things that he taught me. So this particular patient, when I looked a little further, he had an MRI demonstrating that this extensive tumor that he had infiltrated the inferolateral basal wall. So in this case, it wasn't amyloid at all, but I still found it to be interesting. Here's a patient who presented at age 67 with progressive exertional dyspnea. He has a bicuspid aortic valve with moderate aortic regurgitation on his outside echo, the EF about 50, and the walls were borderline increased. That led to a PYP that was positive, heart to contralateral ratio of 1.8. He was diagnosed with wild-type TTR amyloid and started on tafamidis. He decided to come to see us for a second opinion. On our echo, he does have significant LV dilation, 64 millimeters, and he had moderate aortic regurgitation was the way it was read out. These wall thicknesses really only measured about 11 millimeters, but again, he has a dilated left ventricle. I don't have all the images of his aortic regurgitation, but this was a very eccentric jet, and we won't go into the challenges of quantifying aortic regurgitation. But as I listened to the patient, the quality of the murmur was unusual, reminded me of a patient with endocarditis, maybe with a perforation. And there was no reason why he should have left ventricular dilation except for aortic regurgitation. We repeated the PYP scan, and the planar was positive because he has a dilated left ventricle and aortic regurgitation, but specs showed that there was no uptake of the myocardium. When we did a TEE, we were able to demonstrate that he had a flail leaflet of the bicuspid aortic valve due to a torn fenestration, and he had severe aortic regurgitation. So he did not need tafamidis at all. We proved this at the time of his cardiac surgery, where we took a specimen and there was no amyloid at all. The patient just needed aortic valve replacement. This patient and others led all of us to be very, very concerned. PYP is a great test, but we need to really make sure that it's used properly. And Maz Hanna wrote this review in JACC. Dr. Falk and I are co-authors, and I just encourage you that we have lots of examples in there of the perils of PYP, but make sure that you understand that AL amyloidosis can have PYP uptake. Blood pool, if you do planar only, you really need to do SPECT. And if you're suspicious of amyloid and you still get a negative PYP, you should do a biopsy. So how do we avoid these perils of PYP? Make sure that you have a classic echo or a cardiac MRI if you're making the diagnosis. Those were the criteria for the international consensus guidelines. Now, if you are seeing a lot of amyloid patients, including screening carriers, that might be different, but in general, PYP at this time is usually restricted to patients with typical echo or MRI findings. Make sure you always screen for monoclonal protein, and that means serum-free light chains and serum and urine immunofixation. You have to have tissue if those are positive. Make sure you do SPECT, and recognize that there are other causes of PYP uptake. We don't really know why PYP uptake occurs in TTR amyloid. We have a variety of theories. But as I showed you with hydroxychloroquine, there are going to be other things, and we will all be learning more as we apply this test more widely. Here's a patient who has known TTR amyloid. This patient has had an endomyocardial biopsy that showed severe interstitial TTR amyloid wild type. And notice that he has very severe mitral regurgitation, left ventricle, right ventricle. And his LV dimension is 76 millimeters. So this is a pretty interesting patient that one of the fellows got suspicious of amyloid, did actually a PYP, and then went to biopsy because some of these unusual findings. And I was a little shocked when I found out that he had been sent for mitral valve replacement. He was not a good candidate for the mitral clip, but he actually was pretty well compensated from a heart failure standpoint. And when I looked through it all, I decided that normally I wouldn't do that, but I think it was a good idea. So this is a patient with something unusual. You don't usually see this degree of LV dilation in TTR amyloid. But the paths showed that he had extensive amyloid of the mitral valve. So presumably that's what caused the LV dilatation and this unusual phenotype. Just to show you that other types of amyloid can affect the valves, here's a lady with a rare type of amyloid, hereditary ApoA1. Notice the mitral valve is quite abnormal, and the tricuspid valve is even more abnormal, these big globular areas of thickening. That lady actually had a liver and a kidney transplant. We're getting almost to the end of these examples, but I want to show you this 76-year-old lady who's been really healthy. She's biked in every state in the United States, but over 6 years she became very dysmic. Her endomyocardial biopsy showed wild-type TTR amyloid. She had a very astute clinician who noticed that an outside echo suggested her walls were a little bit thick, which they were just barely. But her wedge pressure, which was 16 at rest, went up to 28 with exercise, even though the biopsy showed only mild amyloid. So this was not incidental amyloid. This is a woman with wild-type TTR amyloid. She also had some systolic anterior motion of the mitral apparatus. But this is not an echo that's going to make you think that the patient has amyloid. So she is actually now on tafamidis and on another clinical trial. She's age 81. So back to some of those first patients that I showed you. Somebody who's really paying attention will notice that this one is from May of 2000, and this was a classic 38-year-old heart failure, classic amyloid. Her cardiologist didn't figure it out, but her internist did. She ended up coming here and having a stem cell transplant, autologous stem cell for AL, and noticed that her echo normalized. That took about 3 years. And in case Dr. Candaria is tuning in, he used to kid me about how often I showed this case. Well, I'm showing her now because she's at the 20th anniversary of her stem cell. She's never required any other therapy. She has no heart failure. So this shows us that there is hope for this condition. And same thing now with TTR amyloid. So basically all of these patients have amyloid. These particular examples are all AL amyloid with different variations. So what to do when it's not classic? You need to look for the other areas of thickening, posterior basal, LV wall, RV thickening, unexplained diastolic dysfunction, low stroke volume, endocardial thickening, false positive stress echo. When you're suspicious, you certainly should do strain and correlate with the ECG. And echocardiographers don't need to be the only ones making this diagnosis. You want to have as much history as you can in EKG findings. That can be difficult to do in the real world, but I think it's all the more reason why we need groups like ASE and others to fight for the importance of really having enough time to properly interpret the echo. And again, as a clinician, you're going to see some of these clinical clues. So in the echo lab, we're seeing it all the time. We need to really speak up when we see it and correlate it with the clinical findings. So I'll just end with one thing that I've been challenging echocardiographers, that they can find at least 10 new patients, probably way more than that, depending on your practice, of cardiac amyloid a year. And I threw out that challenge to Dr. Sharon Mulvey a few years ago. And 3 days later, she saw this 55-year-old gentleman who had no symptoms, but his ECG was just a little bit abnormal. She loves handheld echo, so she put down the handheld echo, and this is what she saw. Wall thicknesses of 18 millimeters. This ended up being a positive PYP and a wild-type TTR. So I just want to prove to you it's not always hard. I've showed you some of the variations, but it's not always hard. And here is our Mayo Clinic Cardiac Amyloid YouTube channel and some resources for your patients and yourself. Thank you very much.
Thank you, Dr. Grogan, for that wonderful case-based presentation. It is my privilege to introduce our next and final speaker for today, Dr. Rodney Falk, who is the director of the Amyloidosis program at the Brigham and Women's Hospital. He's also an associate professor of medicine at the Harvard Medical School. Prior to joining the Brigham, he was the associate director of the amyloid program at Boston University School of Medicine, where he was also a professor of medicine. He has authored more than 200 papers, review articles, and editorials, and has also managed to edit a major textbook on atrial fibrillation. He has lectured nationally and internationally, particularly on the topic of cardiac amyloidosis. It is, once again, my privilege to welcome Dr. Falk.
Thank you very much, Dr. Desai, for that introduction, and thank you to the ASC for allowing me to share some of my longstanding interests in cardiac amyloid. What I'm going to do for the next 20 minutes or so is to take a slightly different approach and ask how a relatively rare disease, I call it relatively rare because I agree with Martha, it's not as rare as people think, how a relatively rare disease can teach us a lot about cardiology. Amyloid is an infiltrative toxic disease with a non-dilated ventricle, and a lot of things that apply to general cardiology don't apply in amyloid. But in order to, when you see these things, you can also learn from amyloid and think a little bit outside the box in your general cardiology practice. So amyloidosis, as I pointed out, is a 4-chamber cardiomyopathy. And it may involve the pulmonary vasculature, giving you a disproportionate degree of pulmonary hypertension. It's part of a multi-system disease. So edema, maybe heart failure, edema, maybe nephrotic syndrome in AL amyloid, or these things may interact and make it difficult to use diuretics. There's a preserved EF, which is not preserved systolic function. Preserved EF is severely impaired longitudinal systolic contraction, a stiff non-contractile left atrium, and it causes left ventricular wall thickening, which is not due to hypertrophy, it's infiltration, but may be superimposed on other pathologies so that you shouldn't just think one pathology, and you should think how the two pathologies interact one with another. And as you've seen a couple of cases, it involves the valve, but actually rarely seems to cause severe volumetric left-sided regurgitation. And I want you just to remember that I stress the word volumetric because you have to think a little bit outside the box when you're dealing with regurgitation, and amyloid teaches you about this. So let's jump right in to the 3 or 4 cases that I hope will be able to show you how much you can find that's intriguing in this disease. The first case is a 75-year-old man who for at least 20 years was known to have a murmur attributed to mitral regurgitation, and he was said to have mild to moderate mitral regurgitation. Neither his murmur nor on the local echocardiograms was there any change in the degree of his mitral regurgitation. And in fact, it looks very mild on these 2 views here. His cardiologist was pretty astute, noticed that his wall was getting a little thick and he developed atrial fibrillation, and a diagnosis of TTR amyloid was made. He was minimally symptomatic, other than his atrial arrhythmias. Shortly after we had seen him, a pulmonary nodule was found, and it was thought to be malignant. It was removed by a VATS procedure, and this was followed by recurrent pleural effusions. So lesson number one here is it was, in fact, a malignant nodule. It was nothing to do with his amyloid, but the pleura in patients with amyloidosis is very often infiltrated to the extent that any procedure that damages the pleura may cause not just the usual small pleural effusion, but may cause the pleural effusion that is disproportionate to the degree of heart failure, because these patients will often have cardiac involvement. And there are some patients, particularly patients with AL amyloid, in whom pleural effusions are associated with clear heart failure. But as you treat the heart failure, the pleural effusion, if you tap it, it comes back and comes back and comes back. Those are patients with both pleural and cardiac amyloid. So the question here was, why did he have recurrent pleural effusions? He had an excellent pulmonologist, an excellent surgeon. The procedure was pristine. And yet these effusions came back, and this is what his chest x-ray looked like, and he was draining every other week a liter or two. And we went through a period of saying, should we do pleurodesis? This is clearly related to the damage to the pleura. He's clearly got amyloid in the pleura. And I think that for several weeks or even several months, we pondered the differential diagnosis. Was it his heart failure? Well, it hadn't been a problem for this procedure. Or was it his lungs? Now, those of you who are of enough vintage will remember an old program called The Laugh-In. And The Laugh-In used to give, at the end of each program, something called the fickle finger of fate. And pondering this one day, I was looking at another amyloid echo, and the fickle finger of fate told me, wait a minute, the answer is in the echo. And here you can see a finger floating in a pleural effusion, which is pointing to the heart and saying, wait a minute, think more about the heart here than the pleura. Yes, the pleura involved, but there's also a degree of heart failure that you have not been thinking about. So we brought him back. We did another echo, tipping the echo, getting a somewhat off-axis view. And you can see that he has probably we'll call it volumetrically moderate MR. Yes, admittedly, it's eccentric, so it could be more than that. He had a cardiac catheterization. The catheterization showed a very high V wave. The TEE was read as moderate MR. I don't have the TEE here. And it was decided, despite the fact that there was moderate mitral and not severe mitral regurgitation, volumetrically, that hemodynamically, he actually has severe mitral regurgitation. When we're looking at the echo, we're making an assumption that the atrium is relatively distensible. That's not the case in amyloid. As I pointed out at the beginning, this is a disease that involves all four chambers. So a moderate amount of volume going into a very stiff chamber will give you a hemodynamically severe condition. His MR had not changed over the years. What had changed was the compliance of his atrium. And it had been aggravated by 3 ablations, which give you a stiff left atrial syndrome. So bear in mind, MR may remain the same, but if the atrium changes in its stiffness, then symptoms may really get a lot worse. Mark's brother stuck in a very small cabin on a ship. A lot of people in a small cabin. Moderate amount of volume in a stiff atrium. So the moral is volumetrically moderate MR may be hemodynamically significant in the setting of an atrial distensile dysfunction. Whether it's amyloid, whether it's patients who have not got amyloid but have had recurrent atrial fibrillation ablations, which can give you a stiff left atrial syndrome. The second case is of an elderly African American, a man with heart failure. He presented with heart failure, and this was his echocardiogram. When we had the rehearsal for this and went over it, Dr. Klein asked me, what did the mitral inflow look like? And actually, Alan, I did look. It wasn't a very good echo, but it was a clearly restrictive pattern. He has a probably non-dilated left ventricle. It isn't terribly thick, and the striking feature is that his ejection fraction is really significantly impaired. So he has both systolic and significant diastolic dysfunction, but amyloid doesn't jump out here. He has a long-standing history of hypertension. Strain imaging done on a Philips machine, which a little different from the pictures one usually sees that are done on GE machines, with the showed perhaps some apical sparing, but the apex was down. It's -15. The base is -6. So there is a difference, but it didn't jump out as being a typical amyloid pattern. But because of his age, and because the fact that he was an African American, somebody still raised the possibility: could he have amyloid? The walls of the upper limit are normal, and he underwent a technetium pyrophosphate scan. Before I actually get to that, let me point out here that there are other clues. That's one of the things I want to point out. That the echo appearance here was not clear, but it can distract from the diagnosis. We are not just sitting in a darkened room looking at echoes. That's just merely like feeling the trunk of the elephant or the tail of the elephant and not seeing the whole picture. It turns out that he'd had bilateral carpal tunnel syndrome in his history. This is a different patient, but this is something you may see. And also on physical examination, something that's always worth doing is just flexing the arm a little bit and looking for the so-called Popeye sign. Here are two examples of two different patients. And this is a ruptured biceps tendon. Martha has pointed out spinal stenosis and carpal tunnel syndrome. But the biceps tendon will often rupture, often asymptomatically in these patients. And when we looked at 100 consecutive TTR patients with looking for this sign of just flexing the arm, you'll find it's sometimes more subtle if they've got chunkier arms, but it's there in 1 in 3 patients with wild-type TTR amyloid versus published data on 8 per 100,000 in the general population. And we calculated here that if you have a man over 70 with heart failure, preserved ejection fraction, even before you've looked at his wall thickness, the predictive value of this sign is 66% that he's going to have amyloid. So this was a clue, and in fact, this patient underwent a pyrophosphate scan. This is the SPECT. It's strongly positive, and he was genotyped and found to have the isoleucine 122 mutation, which is present in 3.5% of the African American population. So the moral of the story here is it may be atypical, but look for other clues elsewhere, and then it may hone you in on the diagnosis. The third case is a man with known familial amyloidosis. He actually didn't have atrial fibrillation, but had he had atrial fibrillation and you did a CHA2DS2-VASc score on him, the only thing he had was mild congestive heart failure. So he had none of these features. But on his routine echocardiogram, you can see at the top markedly thickened ventricle. It's noted that his transmitral A wave has a normal deceleration time, and despite the fact that he's in sinus rhythm, and despite the fact that he's never had documented atrial fibrillation, there's no visible transmitral A wave, and he had no visible A wave on his tissue Doppler. This is pretty unusual. Occasionally you can see this appearance in someone who's been cardioverted from atrial fibrillation due to atrial stunning, but this was not the case here. So this is a case of left atrial contractile dysfunction. And these cases in patients with amyloid, or even cases who have atrial fibrillation with cardiac amyloid, you cannot apply the CHA2DS2-VASc score because amyloid patients have an atrium much of the time that doesn't work. The stasis in there is incredible. The amyloid infiltration gives you a roughened surface, which is a nidus for clot. And what happened to this poor guy who was not anticoagulated despite the fact that this had been seen. Oh, and this is his atrial strain. Just looking at the atrial septum, make it simple. This is on the left, normal atrial strain. And you can see that the atrial septum lengthens here about 60% during filling of the atrium. So the reservoir effect, the contractile effect, and the conduit effect is all that he has. He has no filling of the atrium, and he has no contraction of the atrium. It's acting just purely as a conduit. And in his particular case, he developed flank pain and had a thromboembolic event. So if you see this in the presence of atrial fibrillation or not in a patient with amyloid, please anticoagulate, and they will tolerate it. So the moral of this particular story is ignore left atrial contractile dysfunction, your peril in these patients. It's a source of thrombus formation, thromboembolism, even in sinus rhythm. Now, finally, I want to look at life from a different angle and really try and think outside the box. I'm just going to give a very quick quiz here. This is a 78-year-old man with cardiac tissue proven TTR amyloidosis. This is not him. This is somebody else. What was his initial diagnosis? And here's the image on strain imaging. So we're going to throw this open to the audience. Does this image most likely show an anteroseptal infarct due to an LAD occlusion, the typical bullseye of cardiac amyloid, septal myectomy due to a misdiagnosis of something or other, Fabry disease, or just technically inadequate strain imaging? I think that we have a survey. So let me know when the poll has come through. I don't see what the answers are here. I think everyone probably should have voted. I don't see that coming up on my screen. But actually, the answer here is, oh, here we go. So we have 23% anteroseptal infarct, 31% typical bullseye, 17% septal myectomy, 8% Fabry disease, and 20% inadequate imaging. Okay, so in actual fact, what we've got is a pretty decent, it's slightly eccentric, a somewhat eccentric bullseye appearance where the base of the heart, at least inferiorly, posteriorly, and laterally, is much less than the apex, but something is going on in the septum. So if we ignored the septum there and made it all symmetrical, you could say, well, it looks like an early amyloid. On the other hand, what's going on in the septum? Can we put the two together and use Occam's razor? And actually, the answer is yes. What this is TTR amyloid, which was initially diagnosed as hypertrophic cardiomyopathy. You had a septal myectomy, which gives them the appearance of, those of you who said an infarct, is correct, and would have done that. He didn't have hypertrophic cardiomyopathy. He in fact had amyloidosis, but he has two issues going on here. One is his diagnosis of amyloid, giving him a bullseye, except in the septum where he's had the myectomy. And here's an example in a different patient. This is a 72-year-old man with a murmur. And can't see it terribly well on here, but he has a considerable amount of SAM. Here's his LVOT gradient at rest. Here it is with Valsalva. He's got a hyperdynamic left ventricle. He saw 4 specialists in hypertrophic cardiomyopathy. The 4th did an MRI. This is an old MRI. It's over 10 years ago now. But it shows features that are not particularly typical for hypertrophic cardiomyopathy, particularly a large amount of delayed gadolinium enhancement in the atrium. And this particular person raised the possibility it was amyloid, underwent an endomyocardial biopsy. This is his endomyocardial biopsy. And you can see the yellowish orange are the myocytes. This is sulfated alcium blue stained amyloid. And half this myocardium is in blue. It's amyloid. Why this occurs and it's hyperdynamic in these patients is unclear. But we do know that patients with TTR amyloid, which is what he had, do get some degree of true myocyte hypertrophy. And I suspect that in some this is exuberant hypertrophy, giving you this appearance. And it may be that he had a predisposition to hypertrophic cardiomyopathy. He was gene negative for the common patterns, and that this somehow triggered it. But this was truly amyloid. How did we deal with it? Well, if you can deal with hypertrophic cardiomyopathy with disopyramide, we bit the bullet. We'd never been done before with amyloid. We brought him in. We gave him disopyramide. And if you look on the left, here is his baseline. And with Valsalva, as I showed you, within an hour of, I think, 300 milligrams of short-acting disopyramide, his gradient had disappeared. And interestingly, when we looked at the strain imaging, although his ejection fraction looked the same, his MR had got a lot less. You can see that's due to significant decrease in longitudinal contraction from a 4-chamber mean of minus 14% to a few hours later to minus 8%. And that was enough to lessen the gradient. So in all of that story is common things occur most commonly, but sometimes a zebra gallops by. So I hope that we have, I've shown you something that you can learn and take away from amyloid as a rare disease, but teaching us about left atrial stiffness, teaching us about that two diseases can coexist, and teaching us about that not everything that looks like one thing always is. Thank you for your attention.
Thank you so much, Alan. Do you want to take it? You're muted, Alan.
Yes, I want to thank Dr. Falk for an excellent presentation, as well as his humor. So we have time for questions for Dr. Grogan and Dr. Falk. Maybe let me start by Martha mentioned about Dr. Tajik. We both have something in common. We both have an excellent mentor with Dr. Tajik teaching us about amyloid. And I remember one thing he always taught me is never, ever call it LVH when you see increased wall thickness, type ventricle. Don't say LVH. So that's a fellow mistake, and I've seen that at some conferences for the fellow sonographers out there. If you see something that's thick, just thickened ventricle, could be infiltrative, could be hypertrophy. Martha, in terms of the questions about PYP scanning, so obviously there's a lot of guidelines about PYP scanning, and the paper that Dr. Hanna and you guys wrote. Could you maybe go over the false positives and the false negatives, and when should you do a PYP scanning?
Great question. I have to quickly go back to the LVH because we did almost have to wash our mouth out with soap if we said LVH. However, I will comment that in TTR amyloid, especially wild type, the pathologists have shown us that myocyte hypertrophy does occur. So we weren't so maybe wrong as we thought. PYP scanning, I think it's a great test, but remember that the data that led to the International Consensus Panel was a group of individuals with a high pretest probability of amyloid. So we know most about technetium pyrophosphate in patients, in amyloid cohorts. Normally, I think for the average practitioner, it's still best used in patients who have some echo or MRI evidence of amyloid and heart failure. I'd be interested in Rodney's thoughts. When one starts to apply it more widely, kind of as a screening test, there will be most likely more false positives. As I mentioned, the key thing that we see very commonly is people not doing SPECT imaging. So they have blood pool uptake and they just make the mistake. There are bony abnormalities that can cause, make it seem as if the PYP is positive. Remember that technetium pyrophosphate was used to grade the size of myocardial infarction. So if you have someone with a recent myocardial infarction, we've seen mistakes made on that basis. Eventually, other things like Plaquenil, other types of cardiomyopathy, we probably will find that. In the right clinical setting, it's really a great test. I know one of our questions was someone who had a positive PYP scan with a normal echo, no symptoms. I think you really have to look for any evidence of heart failure before you decide if you're going to pursue that further and make sure that it was SPECT positive.
One question I had for both of you, one each, I guess. So in the current context, we are seeing an awful lot of patients with low flow, low gradient AS and low stroke volume, etc. Some of it is AS, but a fair proportion of them may end up being amyloidosis. So what are your pearls in terms of when you are seeing somebody with aortic stenosis, when to look for amyloidosis? Number one, and the other question is, in this current era of echo and strain and PYP and MRI and EKG and looking for carpal tunnel, etc., when do we need to go for endomyocardial biopsy? So two questions.
I'm happy, Rodney, I'm happy to address the endomyocardial biopsy. I think it's fair to say, and Martha has alluded to this in her talk, that pyrophosphate is taken up in amyloid cardiomyopathy due to other types of amyloid, including AL amyloid. Not as much, not as intensely, but there are intense uptake in probably 5 to 10% of AL amyloid. On the other hand, 20% of patients with TTR amyloid over the age of 70 have evidence of a monoclonal gammopathy of unknown significance, which is completely unrelated to, almost certainly completely unrelated to their disease. So positive pyrophosphate scan must mean it has to be taken in the presence or absence of anything else going on. If the free light chains are elevated, advise you a biopsy. If there's evidence of a monoclonal gammopathy, are you missing AL amyloid? Perhaps in specialist centers, if the free light chains are normal with a little spike, you might say, I still believe this is TTR, but that might be an indication for a biopsy. So in terms of, that's aside from the low flow, low gradient. I don't know if you want me to continue. Well, let me just continue on my thought on that. Low flow, low gradient, again, I'm not sure if you have moderate AS and TTR amyloid and are very symptomatic, is this a case of a double hit theory that neither of them alone would have given you bad heart failure, but that moderate AS is enough in a bad ventricle to worsen your heart failure? And there's some evidence that you can safely do a TAVR in these patients, even if your calculated valve area is not really critical, and get some improvement even if they've got myocardial disease. So I think there's a big question there that even if you do find amyloid and you think that the valve is not that tight, you should really think through maybe a TAVR would help. But on the other hand, if it's clearly severe LV dysfunction due to amyloid and low flow, you probably should avoid doing a TAVR. I think this is a case for, each case needs to be individualized.
Martha, what are your thoughts on that?
Yeah, and I think at low flow, low gradient is certainly an important time to think about amyloid. Most of the time that's going to be TTR amyloid, so you could do a PYP scan and you would still do the screening for AL to be able to properly interpret the PYP. But I think that will help you pretty much decide if it's amyloid or not. I do think, the studies to date show that patients with TTR amyloid who undergo TAVR have pretty good results, maybe surprising some in the community. But it's exactly as Rodney said, that's an individualized decision. We have some very, very end-stage amyloid patients for whom, if they happen to have AS, whether it's low flow, low gradient, and whether it's moderate or severe, there are some that it's certainly not going to be appropriate to do an intervention. But we probably will start to see more patients in whom it will be appropriate. So exactly what we should do in our TAVR practices, I don't think is completely clear. Should everybody get a PYP? That I think will be forthcoming with more experience. But the reason I showed the patient that had a mitral valve replacement too is traditionally, I have certainly tried to keep my amyloid patients as far away from a cardiac surgeon as possible. I mean, worried about what type of terrible complications they'll have. But if they are pretty well compensated, the gentleman with the severe MR actually had a pretty low NT-proBNP and was a reasonable candidate. So we are going to be doing more interventions in these patients because they're going to be living longer. You know, some of them, if we diagnose them earlier in life, start them on treatment, they're going to end up having other things, whether or not the AS is always, whether it's related to amyloid or not. So that's where this whole chronic amyloid cardiac dysfunction is going to come into play.
One question there, Alan, you want to take?
Before I get to their questions, one thing I want to ask Rodney about, there's a major interest in LA function. You know, obviously it's very important with amyloid, and actually, in terms of an anecdote, I'll give you an anecdote. When my first AHA presentation, actually working with Dr. Tajik, was on diastolic function and amyloid, and the first question, could be from you, Rodney, or from your area, was about how do you know that this is not atrial systolic failure and not, as opposed to LV diastolic function? And my bright answer was, if you look at the pulmonary vein atrial reversal, you can get some assessment of the atrial contractility. Now we're into strain, LA strain. So could you comment a little bit more? When should we be doing strain in these type patients? Suspected amyloid, you should do LA strain, and how do you interpret that?
I'm not entirely sure what the answer to that is. You know, in early amyloid, as you see the very early amyloid, you have a sort of a typical early pattern of ventricular diastolic dysfunction where the atrium is working okay. You may be able to tell me better than I can answer, Alan, is what actually happens to LA strain in somebody who's got such high filling pressures that even if the left atrium looks pretty normal, it just doesn't have the contractile function. But it still, I think, should have that reservoir function. And so maybe the reservoir function is something to look at in LA strain as an indicator of just stiffness that the atrium can't dilate too much. We don't routinely do it. I like to play with it. I think the pictures are very interesting. To my mind, though, you can still get a lot of information just looking at the tissue Doppler and the transmitral flow. And if the deceleration time was pretty normal, there's a tiny little A wave, I would certainly do LA strain at that point and get very worried about the need to anticoagulate such patients.
I just,
There is a question that has come up. Does the phenomenon of false positive PYP apply to other tracers, example DPD?
DPD is used in Europe, not available here, but yes, they can also have uptake with AL and which is not really false positive, it's uptake due to amyloid and the other more rare types. But same issues can occur. Again, one of the biggest problems is not doing SPECT. We see people where the PYP image looks like an old Polaroid or something. People have these ancient cameras somewhere that they dusted off and they started taking pictures, and you really need to do the SPECT imaging. I might, if we have a minute, just to comment about the left atrium. So just remember, Rodney highlighted it. We have to be so vigilant to look for left atrial appendage thrombus. We actually teach our patients that if anyone tells you they're going to do an electrical shock of your, elective shock of your heart, make sure you've had a TEE, because even when anticoagulated, we often find these left atrial appendage thrombus. If I have a wild type patient who hasn't had atrial fibrillation, I'm always paranoid that we're missing it. We, in our practice, have not started to anticoagulate every single patient because there, obviously there are risks. And I think the last thing is, we see out in the community that many individuals are deciding that our amyloid patients should have a Watchman device, which personally, we don't have evidence, but the concern about device thrombosis, it really is worrisome, and these patients should be on lifelong anticoagulation anyway, so it should be a very rare time that we would want to do a Watchman or other type of occluder device.
I think, thank you so much, Martha. Thank you so much, Rodney. On behalf of my co-moderator, Dr. Klein, I think we are coming close to the end of this webinar. I think this was a very, very interesting webinar, learned a lot of new things. To summarize, the big picture is you have to be careful. You have to look at the big picture, because often there's no one smoking gun. You have to incorporate all the information that is available on echo, multiple tools on echo. You may need multimodality imaging. Sometimes even those may not be enough. You may need to look at the fuller picture, carpal tunnel, macroglossia, all kinds of different things. But we are entering into a very exciting phase in the context of amyloidosis. We now understand more about the disease than ever before. We have newer diagnostic modalities, and more importantly, we have newer exciting therapies that will help in this disease process. So on behalf of all of us, I would like to sincerely thank the American Society of Echocardiography for sponsoring this webinar. Hopefully everybody found it useful. Thank you so much.
Thank you.
Thank you, Dr. Desai. Unfortunately, as he mentioned, we are out of time today. For any questions that were not answered, a Q&A handout will be made available when this Enduring webinar is posted. We would like to thank everyone for participating in today's webinar, and a very special thanks to Drs. Klein and Desai for moderating today, and to our speakers, Dr. Grogan and Dr. Falk. As a reminder, you will be automatically redirected to claim CME when this webinar ends in a few moments. If you are unable to complete the test at this time, you'll have 48 hours to do so, and will receive an email reminder to claim credit within the next 24 hours. Once completed, the CME certificate will be emailed within 2 business days and will be added to the Learning Hub account by the end of the month. Stay tuned for announcements regarding the ASE webinar schedule in 2021. You can register for all live and on-demand webinars through the ASE Learning Hub. Thank you to all, and I hope everyone has a wonderful afternoon.
Thank you.
Thank you.
Thank you, everybody.